Welcome to everyone who came today, and for those who we are broadcasting this, it's a live stream to people all over the world. And so, we're here, but we have people watching from all around the globe. And so welcome to everyone. And this is Cleaning for Health in the 21st Century, and when clean is not good enough. Company that I'm associated with here is GCI, the Green Clean Institute, and this program that we're viewing today is ISSA verified. Of course, today that you're seeing is part of that series that you can find at GCI. So there is what we're talking about today, and Clean for Health and not just for appearance sake is where this business is going and growing. And when clean isn't good enough, and I think that too often we judge the quality of the cleaning product just by the appearance, and we need to go beyond that and look into is it sanitary. So there's me, but I am the author of Infection Prevention for Dummies, and am a instructor of the SITS program with ISSA. That's the Cleaning Industry Training Standards, and the program that you're seeing today is part of that ISSA has verified. So we're living in the 21st century, and we have this 24-hour news cycle, and people watch that. And used to be in the old days that the news was 6 o'clock news, and that was it for the day. Maybe a noon news, but we grew up watching the 6 o'clock news, and now it's this 24-hour news cycle, and they have to fill up those 24 hours with something. And so a lot of what gets touted as news isn't really news. It's a interest story or something like that. But the people who spend time in your building watch that news, and and they spend more time usually at work than they do at home. So what is it that they're worried about in their place of business? So here you have enterovirus. Last year was big news. We had about 15 infants who died of enterovirus, and so that was in the news. This is community-acquired MRSA. This is not the hospital variety, but this is out there in the general public. And just a personal story is my daughter-in-law. This has been about 9 years ago, but she was 37 years old at the time, was spending a lot of time in the gym because she was training to enter Iron Woman competition. That's how physically fit she was, but spending a lot of time with a personal trainer. And she got an infection in this part of her hand, and it was from lifting weights and what have you, and it would start off as a sore and got worse, and within 8 weeks was dead. Left my son with 3 small children. And she got MRSA at the gym. And so it's not just in hospitals anymore. So these are other things that, the community-acquired MRSA, Ebola was in the news last year. Hopefully we won't see it again. This is always in the news, the cold and flu season. Foodborne pathogens, foodborne illnesses are always in the news with recalls. I just heard about another recall today of a product that will actually spoil before the use-by date. And so that's always in the news, it seems like. Measles outbreak, this is the cruise ship virus, and that's always seems to be in the news as another cruise ship that, with 300 sick passengers coming back into port. But what you don't see can hurt you, and I think that we go on visuals, but in our world today, we can't just go by visually clean. We have to go beyond that to the microbiology level. A clean building might be a sanitary building, but a sanitary building is always a clean building. So if it's just clean, it may not be sanitary, but if it is sanitary, I believe it is clean. So our role is to control the growth of these harmful microorganisms, and it's vital to human health. And, so we have this job role of protecting the human health, our population. Removing contaminants from a place of business reduces human exposure to disease and the risk of infection. So we have to remove these contaminants in order to provide a healthy building. And we need to get more focused on just removing those contaminants. And if we do that, then we're miles ahead when it comes to disinfecting. But we need to move away from cleaning for the sake of appearance. I said that, and cleaning for health must become our focus. So to clean for health, we have to, first of all, understand some of these basic bugs. They don't always look like this, but we have to know who the bad guys are. Have a knowledge of how these bad bugs are spread. We need to demonstrate effective hand washing, become an expert at soil removal as opposed to transferring soil from one surface to another. And I think too often we move, if you've ever gone to a restaurant and the person with the bucket and the cloths and they're cleaning this table, and then they go over and they clean the next table and dipping the rag and into the bucket of soil water. And so what you're doing is transferring soil from here to there to there to there. And so we need to stop transferring soil and instead collect it and remove it. Remove it, collect it, and take it away. So we will be looking at the superior power, cleaning power of microfiber cloths as well. To clean for health, one must know the difference between cleaning, sanitizing, disinfecting. Are those three terms the same? No. But when you hear people talk about disinfecting, a lot of times they're talking about cleaning, or they're using these terms cleaning, disinfecting, sanitizing as if they were interchangeable, and they're three separate entities unto themselves. So we need to, in order to clean for health, we need to choose and properly use the appropriate disinfectant and target these likely to be touched areas, these high-touch areas that people commonly touch, light switch plates and doorknobs. And I have my own list of things that bug me, but it's one of the things is, you go into a restaurant, sit down, and then the person who seats you takes the menu and lays it onto your plate or your silverware. And I always just hold out my hand. I said, I'll take that. So, because that's one of those things that, when was the last time that menu was disinfected? And now they're going to lay it on your silverware that you're going to be eating with. So we're going to look at these routes of entry because it needs to get from this surface inside of us. In order for the chain of infection to happen, you have the source, which is the sick person, the means of transmission, and a susceptible host in the right environment. And that's why healthcare is one of those areas that is just set up for susceptible hosts. There are people who are ill. Normally, healthy people aren't really targets for some of these pathogenic things that are out there. So we need to look at these three things, and because these microorganisms can make you very ill or possibly die. I think you've heard the statistics of hospital-acquired infections, healthcare-associated infections. There's about 99,000 deaths a year attributed to these hospital-acquired infections. So that's the equivalent of an airliner with 250 passengers every day crashing. And if that was happening, how long would it be before they shut down the airline industry and find out what's causing these things? But we accept it as it's just collateral damage. We're doing so much good. There's going to be some people that are going to not have the favorable outcomes. But we need to look at every one of those as if it was preventable. So we have this person-to-person transmission of disease. It's whenever someone's coughing around you, it's, things are carried, just being in the proximity of people. It's through inhaling. It's through intimate relationships that sexually transmitted diseases. One lesson learned from the Ebola outbreak in Africa is don't touch another person. That means no handshakes, no hugs, no touching. And in that instance, because the way that this major way that we have of stopping the transmission of a lot of these things is through proper hand washing. We'll cover that a little bit later. But over in Africa during the Ebola outbreak, they were washing their hands, but it was in a bucket, and everyone used the same bucket and washed their hands. And so, you wanted to be the first person washing your hands, not the last person. But that was one of the lessons that we learned from the Ebola outbreak in Africa. If you do happen to touch another person, wash your hands immediately. And that's why handshaking is not as big a deal as it used to be. But person to person, people can infect one another, as you've likely noticed with influenza or the common cold. Here's some other examples of those person-to-person transmissions. HIV/AIDS, Ebola, measles, contaminated hands of healthcare workers. And this one is one of my favorites, Typhoid Mary, who actually worked in a rooming house in Chicago back in the late 1800s. And she was a housekeeper and a cook. And she did not have typhoid, but she was a carrier. And people in the house started dying of typhoid, and they tied it back to Mary, who was, just handing out food and cleaning. And so it was a person-to-person transmission, but she didn't exhibit any active signs of typhoid herself. Object-to-person is the one that we're really concerned about. You can also get sick by touching a germy object, which is called a fomite. And then touch your eyes, your nose, your mouth. Those are all mucous membranes that we transfer from this surface to our eyes, our nose, our mouth. But think about those common touch surfaces that are loaded with germs but rarely get cleaned or disinfected, such as elevator buttons, escalator handrails, doorknobs, especially inside. Have you ever thought about how restroom stalls get cleaned? You guys know this, but so often the door to the stall is opened and you go in, you clean, and then you move to the next stall. You need to go inside, close the door, and clean the handle that everyone's touching, because too often I think we forget about, the inside of the stall. We just prop the door open, go in and clean the toilet and wipe things off and then move on to the next one. But anyway, keyboards, money, remote control in a hotel room. This is one of the germiest surfaces in hotels. A lot of people carry their own little baggie and put the remote inside the little Ziploc bag, and then they'll operate the remote from their outside. But anyway, the gym, I mentioned that earlier. Airport security tubs. I travel a lot, and you get there and you're putting, men are putting their shoes in there and their wallets and their cell phones and their belt and all this stuff, and those shoes just walked out of the bathroom across the way, and now they're inside the tub, and now your phone and your money and everything is in there, and then you're holding the phone up to your face, and so those things I would guarantee are rarely cleaned and disinfected. It's been proven that some pathogens can live on a dry surface for up to 1 year. Does that surprise you, that they can live on a surface unharmed? If they're not removed or killed, then they can live on a surface for up to a year. And then as soon as they get touched by hands, then it can be transmitted. If that surface is not cleaned and disinfected, people will transfer the pathogen from the contaminated surface to their hands. Studies have proven that people touch their face up to 30 times an hour. So, germy hands touch their owner's eyes, nose, mouth. Now the pathogen has found a route of entry. So it's from the surface to the hands to the mouth. This is a hospital room, and this is a MRSA study where they cultured and found MRSA on every one of these surfaces that you see a red star. Now, these were the most contaminated surfaces. The bed rail on the bed. This is something at the headboard. I think it's the suction canister, the overbed table. This is just the edge of a counter right here. But one of the things that you will notice is this leading edge of the privacy curtains right here, that those curtains are rarely changed, only if they're visibly soiled. But this was some of the most contaminated area in that room, was that privacy curtain. So hospitals should have a program where they're changing those curtains more frequently than they are. But so what is one of the greatest risks to patients after admission to a hospital? The greatest risk to you is if you're admitted to a patient's room and the patient before you was isolated for one of these diseases like MRSA. You're 40% more likely to get MRSA if the person before you in that room, in that bed, had MRSA. So what does that say to our cleaning and disinfection practices? They have studied, and not only are people in hospitals not washing their hands appropriately, not just frequently enough, but doing it the right way, the right length of time. They're not washing their hands appropriately about 70% of the time. Now, they've also tested these rooms after they were terminally cleaned, and they found that less than 50% of them passed muster as far as removing, all these, removing these so that there was fewer. You see this is an empty area. And so these were not appropriately disinfected, or you wouldn't culture and find MRSA there. So we have a problem in healthcare. And that problem is that people don't wash their hands enough, and then even if this is clean, then their dirty hands are touching it. And now you've taken it from your hands and transferred it to the surface. Or reverse, you have clean hands, but you touch a germy surface. And then you touch something that's clean, and now it's contaminated. So it's happening, and so just a word of caution is that if you ever are admitted to a hospital, make sure that you're not in a room where previous patients have been infected and isolated, staying in that room. If so, then I want to have it cleaned again. I don't think it's unreasonable to ask that. MRSA infections have doubled in 5 years at academic hospitals. So this is 2012, so that goes back to 2007. But MRSA is one of those things that we're going to talk about a little bit later. But it is one of those that about 30,000 people a year die of hospital-acquired MRSA. There's probably half, again, that many people that get the community-acquired, like my daughter-in-law did. So inanimate surfaces near affected patients commonly become contaminated with MRSA. Personnel may contaminate their gloves or possibly their hands by touching such surfaces, and then contaminated the environmental surfaces. But environmental contamination due to MRSA, this was a study that was done, and it is something that is very telling about hospital protocols for cleaning and disinfection. This is something that is old. It's the chain of infection and how it starts with this infectious agent inside of a person. It could be a patient. It could be someone who, is out there in the community. And wherever I go to Sam's or somewhere and I get the cart and there's always the sanitizing wipes there, I always grab those and sanitize. And for you ladies, don't just do the push bar, but put the flap down in there and wipe that too before you set your purse in there, because who knows the last poopy diaper that was sitting there in that seat. Now you're going to put your vegetables in there and other things. So don't just sanitize the push. Yes?
How effective is the sanitizer?
So hand sanitizers or disinfectant wipes?
Both.
Hand sanitizers are pretty effective if you use them appropriately. I think sometimes people use them when they really do need to wash their hands. So it's this false dependence. So that's my one caveat about hand sanitizers is, don't use them for unintended purposes. Still the best practice is to wash your hands and do it for 20 seconds, 25 seconds. But disinfectant wipes, studies have been proven that unless you train people appropriately, if there's 10 tables in this room, they may clean 5 of them with one wipe and then get a second wipe and do the whole room with 2 wipes when, you need to train people appropriately to use the disinfectant wipes like they're intended, and don't spread, because the tendency is to pick it up here and then spread it back there if you don't switch wipes. So anyway, each one of these represents an opportunity to break this chain of infection that goes all the way from this person to the susceptible host over here. So the chain goes around this way, and environmental sanitation is one of the first opportunities right here to break that chain of infection. Disinfection, environmental sanitation. Down here is another opportunity, and that is hand washing. Down here is another one, is disinfecting and hand washing. So, there are several places around here that what we do is impacted on breaking that chain of infection from one person to the next. And I don't care if you're just in a hospital or just out there cleaning public restrooms. There is that opportunity for this chain of infection to be broken by the proper sanitation and disinfection. And what is the risk of not providing a safe, clean, disinfected environment for your patients? It could be millions of dollars. This family, this lady here, this is out in California, but this was from a hospital where the newborns were placed in newborn bassinets that one of the babies had MRSA. And because of ineffective cleaning and disinfection, there was about 7 other babies that got MRSA from the one baby. And this was a class action lawsuit, and we don't know how much they settled for, but every child that was ever in that nursery after the baby with the MRSA, all those families were potentially impacted and awarded a nice sum of money. And it doesn't do anything for the pain and suffering of the families, but by not doing a proper job of cleaning and disinfection, the cost of your facility could be millions. This guy here, his son was entered into the hospital with MRSA, and he was subsequently discharged, went home, and about a month later, the dad started getting some of the same sores. Went to the emergency room, same hospital, and said, "My son was just here. He had MRSA. I think I've got it." And they said, "No, you don't." 5 days later, they took him to surgery. When he came out, he was minus his legs and his arm. And so this is a case where, again, millions of dollars were awarded to this family for misdiagnosis, mistreatment. Now, cleaning and disinfection may not have had anything to do with, well, the first one with the infants in the newborn nursery, but this other one, when you take someone home with MRSA from being discharged, you need to clean your house like you did the hospital. Otherwise you're going to wind up getting it. So, I think this is an opportunity for home cleaning businesses that when someone is discharged from the hospital and the patient goes home, then, there's probably some special cleaning needs to be done in the home. Because before they went to the hospital, they had it. So anyway, born on blood, and I won't go too deep into that, but you have these blood-borne pathogens. That's why we have the OSHA blood-borne pathogen standard. And born on air, so these dust particles that float, if the sunlight was coming through the window and we'd see the tiny dust particles, those things are laden with bacteria, virus, and so they settle onto surfaces, and so they get carried in the air currents and the heating and air conditioning vents, and the filters don't really necessarily filter out those small microns of viruses and bacteria. So, there's an opportunity for things to be carried: anthrax, smallpox, measles, you see the list there, and even C. diff, which is considered to be a contact isolation, but studies have shown that it's also airborne. Via insects, this is one of my personal favorites, through mosquitoes, malaria, West Nile virus, but the common household housefly carries over 100 pathogens, and you see them there. Anthrax. So think about the family picnic, and the flies that are on the potato salad were just on the dog dirt in the park, and now they're sitting on the potato salad. And so, they do carry these diseases, and so we need to control those. Pigs, were the originators of swine flu, and now we have back in the, this is a fairly recent story, yikes, fairly recent story. What I need to do. Well, don't touch it. Okay, but, back in a 4-year period in China and Europe, there was 50 million people who died of bubonic plague. Well, this is just earlier this year, infected flea bites human beings. They developed bubonic plague, and so it never has gone away. It's still around today and infecting people, but it's carried by fleas on rats. So people are your most important, or your most essential infection prevention and control element. There's typically a positive correlation in enhanced patient satisfaction with increased interaction with members of the healthcare delivery team, and especially your environmental services technician. So with the importance of this guy's role, how can your hospital implement effective infection prevention protocols and housekeeping when they are often the first casualties in budget cuts? I think that we have cut the housekeeping departments to a dangerous level in healthcare, and at a time when hospital healthcare-acquired infections are going up, the staffing is going down, and they're expanding, adding space, and it is a tough business proposition to make when all you do is cut the housekeeping. A clean hospital environment can only happen with a strong environmental services team. So I don't care, the best process technology will ultimately fail if the person expected to deliver them struggles with low self-esteem, poor training, too little time for the task, low pay, and poor management. So whatever protocols that we develop, it still has to be delivered by that $9 an hour employee who is struggling to meet the rent. And so, this person is an important member of the infection prevention team, and she is the lowest paid person in the hospital, probably. So the person on the front line of the battle could be called a housekeeper, a cleaning tech, matron, whatever, but that does little to convey their essential role of preventing or controlling the spread of infections. And the time has come to turn this person not just a housekeeper, but to turn them into certified EVS technicians. And by certified, I mean that they are working around certified, registered professionals, healthcare professionals. And it's time that we elevate that position from just a housekeeper to have a certification program and properly educate them on the whys of what they're doing is, I think, more important than the how-tos. But once they understand the whys of what they're doing, they'll understand the how-tos. So we have this certified EVS tech. The time has come to start turning cleaning professionals into certified techs. Infection prevention and control will only become a reality when the certified EVS tech properly regarded, educated, equipped, and compensated. When we have this discussion about $15 an hour employees and you consider the important role of the housekeeper in infection prevention, then comparing that to someone who works in the drive-through at the fast food restaurant, I don't think is a fair comparison. And I believe that this person's responsibility is much greater and deserves much better pay, much better compensation. But along with that is they have to be certified. And no one who is cleaning the OR or cleaning patient rooms should be doing so unless they are certified. But a certified EVS tech must be well trained. It should be a national or international accredited training program. And we do have that. ISSA SITS program is the program that I introduced to you earlier. But they need to be equipped with the best-in-class tools to clean, sanitize, and disinfect. They need to be allotted the proper amount of time to do their jobs. And, I just retired from 34 years of cleaning and disinfecting hospitals, but I can tell you that our standard was 15 minutes a day was the amount of time allotted for that housekeeper to do the daily cleaning. And then she was given 30 minutes for a checkout cleaning. And as I think back on it, I don't think that's enough time, but you do with the staff that you're given, and you've got a certain number of rooms, and so it works out to be about 15 minutes a room. But I think that should be increased, but it will result in an increase in staffing. And in this time when budgets are going down, it's tough to make a business case unless it's that we're preventing infections and saving lives, which is our true role. Then when the C-suite understands that, then we will reverse that trend of cutting the budgets. But they need to be educated about the prevention and transmission of disease. And I think that is one of the missing links, that they just see themselves as cleaners like in a hotel room and not as infection preventionists. We can't wait until the pandemic is upon us to raise up this army of certified EVS techs. There simply won't be enough time. There are over 2,000 hospitals in the U.S. that lost millions of, this is Centers for Medicare and Medicaid government reimbursement. It was just an article in the St. Louis Post-Dispatch recently that the only 2 hospitals in St. Louis that got all of their reimbursement back one of them was St. Luke's, which is where I work. So I think that speaks to, you know, a good cleaning and disinfection program. But anyway, all the other hospitals in the St. Louis area did not. So it's a big deal, and, you know, so this is a financial impact on hospitals, and hopefully they're going to see that having this certified EVS technician will help alleviate some of the problems with these healthcare associated infections. So when we talk about clean, whenever I ask people to define clean, you know, they usually talk about, well, it's vacuuming, it's cleaning the toilet, and it's wiping everything down, empty the trash, and, you know, those are the steps to cleaning. But the real definition of cleaning is no dust, no spots, no smudges, no smells. So if you think about, you know, whether you're talking about this surface or the carpet, or, you know, it can be surfaces, it can be rooms, but whenever you're talking about how do you know that it's clean? We know it's clean because there's no dust, no spots, no smudges, no smells. Removing soil is always the guiding principle, and it's always, the guiding principle is always to remove germs if possible rather than kill them. I think for too long in this country we have depended on disinfectants to kill the little boogers when we ought to be removing them. And if we can do removal at a level of 99 to 99.9%, if we can remove them with just good cleaning products and the right microfiber products, then it doesn't leave much food there on the surface for bacteria to feed on. Bacteria need three things to live: food, water, and oxygen. And if you remove any one of those three, they cannot survive on the surface. So if we remove their food source, 99.9%, then there's not much left there for them to feed on. So I think that we ought to do a better job of removing the soil, and then with the soil goes all the bad guys. To reduce airborne dust and germs, remember I talked about dust, carrying these and then depositing bacteria and viruses on horizontal surfaces. The best way to do that is with an EPA registered disinfectant, or even better is a HEPA filter vacuum that you know, will take care of that high dust and some of the horizontal surfaces in the room. So the process of cleaning, cleaning is if it's done correctly, removes the food and moisture necessary for microorganisms to survive. Most chemical disinfectants cannot do their job with high levels of organic soil present on the surface. I talked to a disinfectant manufacturer, and because disinfectants are registered, it says right on the label, in the presence of 5% soil. And I asked, if soil is visible on the surface, what percentage are we talking about? And she said probably 20 to 30%. I said, but your disinfectant's registered for 5%. She said, if it was up to me, I would take the 5% off, but EPA won't allow me to do that. So it's on the label, it's the standard, but if you clean the surface and then take a white paper towel, wet it, and you go over that surface again, and there's any color other than white, there's still soil on the surface. And we have, then when your disinfectant is used on that, it's fighting the soil and cannot kill the bugs that's in, you know, that's on the label as listed as a kill. You know, so the soil interrupts the killing power of the disinfectant if we don't do a good job of removing, and that's why I say cleaning and disinfecting is a two-step process. It's not a one-step process. I don't care if you have a one-step product, cleaner, disinfectant. I challenge you that it's as effective as pre-cleaning a surface and then applying the disinfectant. When 99 or 96 to 99% of the soil is removed from a surface, sometimes with just microfiber and water, chances are the bad guys are gone too. So what's the difference between sanitizers and disinfectants? Just a high-level view here. Sanitizers are generally used on food preparation surfaces, something that or something that's occupied by infants and toddlers, where disinfectants would require a second step of rinsing. Rinsing would be necessary if the preparation of food on that surface wouldn't pick up toxic chemicals. And also would be required on surfaces where infants and toddlers might touch the surface and place their hands in their mouth and ingest the toxic chemicals. So you would need to rinse as a final step in either of those situations where it's a food preparation surface or where infants. Now think about, the waiting room at the doctor's office where, the toys are and all this, and, toys are always a big deal with toddlers because they stick everything in their mouth. And so even if you disinfect those toys, you need to, after they're air dried, they need to be rinsed before putting it back out for infants and toddlers to touch again. Disinfectants are not usually sporicidal, but some are, and that is that they kill C. diff spores. And there's a new generation of disinfectants coming along that have a C. diff kill claim. And disinfectants are usually a chemical agent, but sometimes can be a physical agent that destroys disease-causing pathogens, harmful microorganisms that might kill bacterial spores. But they are always applied to inanimate surfaces, and that means not to anything that's human, like people washing their hands with disinfectants. That's not their intended use. Their intended use is to use on hard, non-porous surfaces. The EPA groups these disinfectants into limited, general, or hospital disinfection. So if sanitizers kill 99.9%, that's a 4 log 10 reduction. So that's good, right? 99.9% is good. Well, disinfectants kill 99.9999%. Now, what's the difference? Here's the difference. If we start with 1 million pathogens on a surface and we are satisfied with 99.99%, there would still be 10,000 pathogens left on that surface. Norovirus needs about half that amount to flourish. But if we kill 99.9999% disinfectant, then there's only 100. Big difference between 10,000 and 100.
Question, can you explain log?
Log is, it's an exponential, so instead of having this number with 14 zeros behind it, and we can't, 1 million is what? 1,000 thousands, and 1 billion is 1,000 millions, and 1 trillion. So you run out of terms for the log reduction, but when you're talking about trillions of pathogens on a surface, then you're looking at the log reduction. And so it's a log 10, so if it's 1,000, it's 1,000 to the 10th power. So I'm not a mathematician, but it's a big number. It's a really big number. So when we're talking about disinfectants, then you're looking for a 6 log reduction, and that is this 99 point. So this is the 6 log, this is the 4 log right here.
The second question was, which is best?
Which is best, the sanitizer or disinfectant? Disinfectants. Sanitizers would only be used in the dietary department where food preparation is going on, that because you don't want to use a disinfectant there necessarily because you would have to rinse the surface after you're done. So in a hospital, disinfectant is what you want to be using anytime that you're dealing with patient room cleaning and not a sanitizer. So a big difference between sanitizing and disinfecting. So there's a proper application of disinfectants. How should cleaners and disinfectants be used? There's this talk going on about the way that we apply disinfectants. You go into a restroom to clean, and people are taught to spray the disinfectant over everything. You know, give it its 10-minute contact time or 5-minute contact time, whatever the label says. But remember what I said about the soil. If the soil is so heavy on these surfaces with urine and other things, soil is on surfaces in bathrooms. Let's just give that. But, you know, if we're spraying disinfectant so it gets its contact time, it's not effective because it's fighting the soil and cannot disinfect, cannot kill anything because of the soil present on the surface. So we don't spray disinfectants. It's a health risk. We had an OSHA inspection, and the inspector asked me about, you know, I saw disinfectant bottles with spray makers on all of them. I said, yes, what's the problem? He said, are you aware of the occupational hazards of spraying disinfectants? I said, I've heard about studies that have shown that, you know, housekeepers get this chronic upper respiratory problem. He looked at me and said, what would the prudent man do? I said, I guess we wouldn't have sprayers on any of our disinfectants. He said, bingo. And then he counted how many he saw in the hospital. We got a $75 fine for every one of them. Now, how often are we spraying disinfectants? You know, it comes on a Lysol disinfectant spray. You'll see it sitting in the staff restroom, you know, and it's there for the staff to use, and they spray it in the air and go, that smells good and clean. You know, they're breathing that disinfectant into their lungs, and the disinfectant doesn't know the difference between the good germs and bad germs. It just kills them all. And so it is a chronic health problem for employees who use disinfectants. So what we did was we got the flip tops on all of our disinfectants. And I would say that about most cleaning chemicals, you don't need to be spraying them because you're atomizing that. I said, well, we can control the spray on there to where it's a coarse stream. He said, you can go around, check every sprayer every hour. He said, get rid of the sprayers, go to a flip top, or the other way would be use an open bucket and put your cloths in there and you're not spraying anything. Contact on the label is less important. Just let the wetted surface air dry. CDC has said that if a surface remains wet for at least 90 seconds, the kill has already happened. There's at least 14 scientific studies that say if the label, you know, all these three products, if one was a phenolic, one was a quaternary ammonium compound, and the other one was a bleach product. And they were tested, all three of them. See what, wherever that disinfectant is, you know, registered in the lab, there is no cleaning cloth and the disinfectant on the surface and this going on. It's in a petri dish or on slides. And there is no mechanical action whenever those products get their registration. So the contact time is less important than just let the surface air dry. So don't wipe it with this disinfectant cloth and then have a dry cloth here and drying it. That's what you don't want to do. But as long as it air dries, CDC says 90 seconds is all it takes. This other study showed that they reached a 5 or 6 log reduction in the first 60 seconds, and then it plateaued from there. So disinfectants, I think people have this misconception that the surface has to, if this surface, and I'm cleaning it, and it dries in 2 minutes, and you have a 10-minute contact time on a product, I've got to stand here and after it's dry, go back and wipe it again. I would have to do that 4 times to get the 10-minute contact time. That's not happening. Real world situation is we're moving and grooving. We've got 10 more rooms to do before I go home. And so it's allowed to air dry, and it's the mechanical action of the cloth that's doing the work. Be sure the disinfectant does not damage the surface. Always wear nitrile gloves. This is another lesson we learned from our OSHA inspector, but we were using just latex exam gloves, and he said, have you ever noticed that whenever you have your hands in a bucket of solution and you take your gloves off that your hands are wet? I said, yeah. He says, that's not sweat. He said, that's the chemical passing through that latex exam glove to the surface, and you read the MSDS or the SDS, and the route of entry is through the skin. So we're using these inferior gloves cleaning with, and with these chemicals that, you know, are dermally toxic. They're toxic to the skin. So he asked for a letter from our glove manufacturer that says it's okay to have those gloves in disinfectant for 8 hours a day. I said, there is no letter like that. He says you shouldn't be using any gloves that you can't get that letter from the company and say it's okay to use them in the, you know, submerged in cleaning chemicals. So CDC says that the best practice is our cleaning process must minimize contamination of cleaning solutions. Bucket solutions become contaminated almost immediately if we use the method of returning soil wipers or mops to the cleaning solution. Now look at this. After using this disinfectant wipe right here, would you A, throw it away and get a fresh wipe to continue, or return it to the canister so it can be recharged with the disinfectant? Then why do we do it with wipers and mops? The preferred method of using mops and wipers in a bucket solution is set the bucket with a properly mixed disinfectant or cleaning solution and placing clean wipers and mops in the solution. Always, whenever you're reaching into the water, you're pulling out a clean, fresh charged wiper or mop. And the soil one never goes back into the bucket because you're just taking it from here and contaminating the water. Never return a soil wiper or mop to the clean solution. Now I want to talk about a dirty little secret that not a lot of people in the environmental services profession know about, the role that biofilm plays on dry surfaces and wet surfaces. This is this tabletop surface right here, the substratum. And then you have this biofilm that builds up right here. And this is, this is like taking a piece of saran wrap and putting it over the top of this. This is the boundary layer. And, the way that this interacts on that surface is, as we'll see, if I cleaned and disinfected the surface and I used an ATP meter, an ATP meter measures the amount of soil on a surface. So I use an ATP meter before I clean and say it's 600 because this is a conference room table. It's 600. I do a cleaning and disinfectant wipe down, and instead of 600, I do an ATP reading now, and it's 30. If no one touched this table, I could come back in 4 hours, and because of this biofilm, it would repopulate that surface, and in 4 to 5 hours, I could come back and ATP this table when no one's touched it, and it's back up to like 300. Because this stuff comes out, once the danger is gone, it comes back. It's like living underground, and then it comes back to life, after the danger is gone. According to the Health Facilities Institute, biofilms are around us everywhere in our office, even in our bodies. Whenever you wake up in the morning, you feel that film on the inside of your mouth, it's a biofilm. By you brushing your teeth, you will get rid of the biofilm, but you still need to go to the dentist every 6 months and remove the plaque, because the biofilm that you don't remove turns into hard plaque, and that's what I just showed you on this. This is like the plaque. If you don't remove this, then you're setting yourself up for an inadequate cleaning and disinfection protocol. So most times, however, you cannot see biofilm directly with your naked eye on a clean-looking surface like a stainless steel countertop in the kitchen. The stainless steel is shining, but there's very likely not biofilm free. Biofilms are a real challenge. Many EVS teams don't know much about them. They're very difficult to remove. Disinfectants by themselves won't do it. In fact, they can only be removed through aggressive scrubbing and microdenier with a microdenier product. Biofilm can be removed by using the right disinfectant dwell time. That's a myth. It's not true. Biofilms have been known to survive submerged in disinfectant for 20 minutes or more. So disinfectants won't remove the biofilm. And scrubbing, also known as good old-fashioned elbow grease, is the best way to prevent and remove biofilms. I said that to a group, and one young lady raised her hand and said, "Where do you get that elbow grease?" And I said, "I'll have my grandmother explain it to you." She thought it was something that you bought, No, your grandmother taught you. Yeah, Dave.
Questions, I think, on the biofilm. Can you explain the oxygen and environmental load that is on the slide?
This is the oxygen concentration. So oxygen can't get down to here because of this boundary layer. So this biofilm, the oxygen concentration is low, and then whenever the oxygen is reintroduced, through time, then this, comes back to repopulate the surface. So, there's not much oxygen with this protective layer, but then whenever, you disturb this without removing this, then you're introducing oxygen to this, and then it repopulates. So it's the oxygen that makes it come back to life. Biofilm needs to be removed daily from environmental surfaces in order to break the chain of infection and prevent cross-transmission. The question was the most effective way of removing biofilm on a daily basis. And that's with a microdenier wipers, mops. The mechanical action of just a cotton cloth, we're going to see that here in a little bit. The cotton cloths are not effective surface cleaners. Same way that terry cloth towel is more absorbent than a cotton t-shirt because it's thousands of tiny loops. Microfiber tools supply more aggressive cleaning action because they have increased surface area and holding space for microsoil. The thick matrix called biofilm is broken up or disrupted and removed with the correct microfiber textiles. Microfiber helps physically remove the food and moisture necessary for microorganisms to survive. Use microfiber with a disinfectant solution for the best results. Not all microfiber products are created equal, so buyer beware. You can buy them at Sam's, a bag of them for $20. 40 wipes for $20, or you can buy something else. And so you just need to be aware that this is the commonly used microfiber, and you see the size of these fibers. But a split microfiber, this isn't how it actually looks. This is right before it falls completely apart. But each one of these becomes a cleaning surface. This is right before it splits completely, and this is an ultra denier. This is a regular microfiber. So you see the surface of this as opposed to that one. High performance clean textiles have over 300,000 fiber ultra deniers. That's where, so 300,000 per square inch is the ultra denier. That's this with each one of these pieces of pie becoming a separate fiber unto itself. Fibers smaller than 0.1 micron are needed to pick up many pathogens such as the H1N1 flu. So a product with larger blades, a low percent of microfiber, and small quantity of split fiber will fail to remove most pathogens, let alone costly these multi-drug resistant organisms such as MRSA, VRE, or C. diff. You know, just a ultra-denier cloth with water will pick up the C. diff spores, and you don't need a disinfectant necessarily, but you have the right microfiber that if you can collect the C. diff spores in the cloth and it's held there and not released, then that's the best solution. Processing, we need to get away from the term cleaning. By now you're getting the picture that a properly processed room, no matter where it is in your facility, should be sanitized, orderly, and properly maintained. A sanitized room is a clean room, but we need to move to the term process, which includes cleaning and disinfecting an item or an area using a clean microdenier cloth or flat mop, an appropriate and approved EPA registered disinfectant. We don't clean an operating room, we process it. So cleaning has different connotations, but if you use this term for processing a room, then it has these elements: the ultra denier microfiber, EPA registered disinfectant. So we don't clean operating rooms, we process it. We don't clean a patient's room, we process it. Now here's another little known fact that quats and cotton don't mix. A quaternary ammonium compound, chloride compound, I don't care what generation it is, quats is what they're commonly referred to, used on hard surfaces in the U.S. today. The active ingredients in quats is absorbed into the cotton fibers. So that if you're using a wipe removed from the liquid and excess solution, so if I have a bucket of quat disinfectant here, and there are papers that you can use to test the parts per million. So if the label says it's effective at 600 parts per million, I use this detection strip, stick it in there, I put it on there, compare the colors on the chart, and 600 parts per million. Then I put the cotton cloth into it and wait for 2 minutes and then test the solution, or if I dip the cloth in there and then wring the solution out onto this surface and then use the same test methodology, it's less than 600 parts per million. The cotton absorbed the active ingredients in the quat. And so then you're off label because it was registered with EPA at 600 parts per million. And now it's less than 600 parts per million. So you're off label and you're in violation of the product's label. So, a closing thought. One well-trained, well-equipped, conscientious, certified EVS technician given the proper tools and an adequate amount of time to clean a room will prevent more infections than a room full of doctors can cure. And we don't know how many we prevent because they never happen. But how many lives have we saved? Because once you get one of these infections, a room full of doctors may not be able to cure it. These multi-drug resistant organisms are coming along now. We're entering the days of pre-penicillin. Remember, penicillin was discovered by Fleming back in the 40s. He predicted that within 2 years, there would be organisms that were resistant to penicillin. When was the last time you heard anyone prescribe penicillin? It doesn't work. So we've got these antibiotic resistant organisms now that there are no antibiotics for. And so in that world, cleaning may be the only thing, proper cleaning and disinfection may be the only thing that saves mankind because there are no antibiotics. And they aren't being discovered because there's no money in them. For these big pharmaceutical companies, they're going to put their R&D into something you take for the rest of your life to reduce your cholesterol, reduce your blood pressure. Those kinds of medications is what they're putting their R&D in to, not something that you take for 5 days and you get better and you don't buy it anymore. So no new antibiotics on the horizon, and we have to deal with what we have, but we need to have certified EVS technicians out there doing this, the real work of infection prevention and control. The EVS technician that I've kept referring to, this is an actual certificate that would be issued to someone who took that course, and you see that it is ISSA CITS verified, and so people who go through the EVS technician course can become certified. And there's that, and if you go to this site, you can get more information about it. And then there's my information. So I'll open it up to any questions that you might have. Well, I thank you for coming today and your attention, and I'll stick around for a while if you've got any questions for me. But thank you for all those who have attended today,